Secretary.
Thank you, my lady. Mr Hancock, can we stick with a few questions, please, about PPE, and then I have a number of other topics to cover with you this afternoon. At paragraph 199 of your statement, I don't need it called up on screen, but you set out there that you received a submission from the PPE demand team at the department on the 15th of July proposing free distribution of PPE to frontline primary and social care services, initially until March 2021. Is that right?
I'm sure it is.
Well, I'm taking it from your statement.
Yeah,
and you thereafter extended the free PPE to March 2022.
Right.
All right. Obviously, that postdates, the end date postdates your leaving the department. But can I ask you about unpaid carers, please?
Yes.
And PPE for them. And can I call up on screen, please, INQ 328012_4. Now, this is a submission, in fact, to the Minister.
Right.
I'd like to ask you about a few things in it, if I may. If I ask you something and you can't answer, please, will you let me know? All right. It was a submission to Helen Whately in November of 2020, asking her to amend guidance to advise PPE should be worn by unpaid carers when providing personal care to someone who they do not live with. All right, just to help you. Okay?
Okay.
And can I ask, if the submission goes to the Minister, do I take it that it doesn't come to you?
Correct.
Would you expect, though, a submission like this for her to speak to you about it or to ask your views on it?
No.
All right.
If it's just to her, as opposed to her copying my private office or copying, or to her then me, I'd see it. Otherwise,
fine.
And especially with a minister who I delegated a lot to.
All right, fine.
Essentially, in government, the civil servants work out which junior ministers the Secretary of State trusts and which one he or she doesn't. And in this case, they'll know that I would have agreed with whatever decision.
And so we shouldn't take this as signifying that you weren't interested in unpaid carers. This was just one of many tasks that you no doubt delegated to Helen Whately.
Precisely.
All right. And we've seen the recommendation there is that she amends the guidance. And I'd just like to see it your help, please. On page 2, we have a summary of the position as it was and then what the plan was. The DHSE guidance for unpaid carers in England does not currently, so as at November, recommend that unpaid carers need to wear PPE when providing care, unless advised to do so by a healthcare professional. In May 2020, PHE advised that carers who didn't live with the person they were caring for should wear PPE if providing personal care, and that co-resident carers should wear PPE if the cared for individual has COVID symptoms. So that was the position with the guidance. You were obviously aware that there were many millions of unpaid carers. Estimates vary between 5.5 million and I think about 7.7 million.
Well, it all depends how you define it, so yes.
Quite. And it's obvious, isn't it, Mr Hancock, that there was not going to be PPE necessarily for all 5 to 7 million unpaid carers providing personal care?
Well, that's a perfectly legitimate decision for an elected government to make PPE available for free to everybody if they wanted to, but there is a limit on the public purse.
No, quite. It's not a criticism. It's
no.
A fact here that if we wanted to provide PPE for those many millions of people providing unpaid care, it would obviously place significant demands on the availability of PPE.
Yes, and the cost to taxpayers, yes.
All right. Can I look, please, at page 5 and paragraph 7? The data on unpaid carers, sorry, it's my fault, I just jumped to the paragraph above to give some context. The data on unpaid carers, including how many there are, the types of activities they do, and whether they are extra resident or co-resident, is limited. Does that accord with your understanding of the data available on unpaid carers?
Yes, I'd say it's not only that it's limited, it's also a definitional question. So I would have taken, if I'd had a piece of advice like this, our best estimate suggests there could be as many as 7.7 million. I would have said, well, what does that mean? What about an elderly couple where one of them is in slightly greater disrepair than the other? Does that count? You know, it's really hard to define what an unpaid carer is and isn't.
Understood, but did the lack of a definition in any way impede or hamper the pandemic response to unpaid carers?
The way that we handled this primarily was through the shielding, where there was a definition of the risk to an individual, and then that individual's carers would be brought into the programme, either directly or indirectly. But it does mean that the whole subject of policy around unpaid carers is complicated by these boundary definitional issues. Some people are obviously unpaid carers, and nobody would dispute it. Others, it's just, people caring for each other. What does that mean in a formal policy sense? It's quite hard to define.
No, so that was to ask the question again. Did the lack of definition, though, in your mind, hamper the way that you approach the pandemic response to unpaid carers?
Well, the word hamper has a pejorative sense.
Well, I don't mean it pejoratively.
No, but my answer isn't a yes/no, because it's not really a yes/no thing. It's not a legalistic thing. It's just a piece of context you have to take into account when making policy in this area.
All right. The paragraph says clearly providing all of these carers with PPE would be unfeasible from a stock, supply and distribution perspective.
Yes, and I would add taxpayer as well. I mean, we spent a lot of money, but there was still a consideration of the taxpayer.
Okay. And then the next paragraph says it's unclear how many unpaid carers would take up an offer of PPE.
Yeah.
Currently in Liverpool regularly provides approximately 8 unpaid carers with PPE out of an estimated 52,000. Now, I know you said that the Minister wouldn't necessarily bring this to your attention, but were you asked at all for any of your views about the feasibility or otherwise of providing PPE for unpaid carers?
It was an item that we discussed. I don't precisely remember when, but unpaid, essentially, in the continuum of concern, unpaid carers are there, but less concerned than those in hospital, for instance. And so of course it's a consideration, but I would say that mostly I left policy towards unpaid carers I delegated it largely to Helen.
All right. But that can come down, thank you. You did, in fact, though, if I can remind you, by reference to your statement, I think you agreed to a proposal of a trial of free PPE for unpaid carers in November 2020. And in fact, in due course, then you approved a national rollout in January 2021.
Right.
Can you help us with why it was you agreed both the trial and, in due course, the national rollout?
I imagine because they were proposed to me with Helen's support, and I backed her judgment.
It may be suggested to you that the trial in November and the rollout in January 2021, to some, might look that unpaid carers are an afterthought, given that there was PPE provided to both care homes and the domiciliary care sector before that. Are you able to help with whether there was an afterthought here to unpaid care?
No. The word afterthought, which you've used a few times, is a rhetorical device to imply there was less consideration given, which is false and wrong. However, the context means that the acuity of concern was less by the nature of the group. That is an appropriate and reasonable position to take when you've got to deal with a huge number of things, and you therefore have to prioritise.
From your perspective, was there anything else you think now, upon reflection, you could have done earlier in the pandemic to provide additional support to unpaid carers?
I'm sure it's worthy of consideration. It's not an area that I was particularly close to. And I'm sure it's a question worth asking Helen, and I'm sure she'd come up with some sensible suggestions. It's just not something I'm particularly close to.
All right. Fair enough. Finally, on the topic of PPE, I said earlier this morning that you were in favour of all health and social care facilities keeping a PPE supply themselves for use in an emergency.
Yeah.
Can I ask you, how practical do you consider that to be for perhaps smaller care homes with less buying power, less space, limited shelf life of PPE?
Well, if they're smaller, they need less PPE in their stockpile. So a stockpile will be proportionate. You wouldn't have the same size for a big care home as a small one. Everybody's got a cupboard. And so it's totally reasonable to require a degree of PPE, say a month's supply You can pull any time period out of the hat, but a month would seem reasonable. That would take, in a small care home, that would take you would need obviously a storage facility for that, but it would be relatively modest. But the impact of it will be really great because it will give you a month to sort out all these problems that, it took us more than that to really get the system going.
Right. What about domiciliary care? Would you make the same recommendation that providers of domiciliary care have their own supply of PPE?
Yes.
I presume not, though, for the reasons you just alluded to. You wouldn't be in a position to make a recommendation about that in relation to unpaid care.
No, I think unpaid care is different in its nature.
All right, understood.
And also, there's no levers, there's no contract, there's no, you can make a recommendation, but you couldn't enforce it in any way.
Okay. All right. A topic that you have also referred to this morning was that of visiting restrictions.
Yes.
And can I come back to that, please, just to get your overall views? Clearly, there is the protection of the residents versus the impact on them and their loved ones. And you mentioned this morning trying to strike the best balance, to use your words, in this difficult area. Did you ever consider asking for studies to be done about the extent to which visitors brought in COVID-19 into care homes?
Yes, that was part of the understanding, and I think you put it well earlier when you said broadly that the disease got into care homes through residents, visitors, and staff. I mean, essentially through people. That's how the disease spread.
Yeah. You are aware of the real upset, and you've mentioned it yourself a couple of times in evidence, that the visiting restrictions caused on a number of people who couldn't be with their loved ones when they died.
Yeah, of course.
No, it's not a criticism.
No,
Just
I don't take
laying
it
the
as a criticism. I just think it's awful. I mean, some of the things that people went through were truly ghastly, and it was an awful virus.
Yeah. I wanted just to pick up on one contributor to Every Story Matters, who said, perhaps not in the context of elderly people or those with dementia, but a loved one of a resident in a care home said this: "My son has severe autism and learning difficulties, has no speech and limited understanding. He was in a residential care home. I was unable to visit him for 24 weeks. We couldn't visit through a window or FaceTime, as he would not understand, and so became upset. It was a choice between keeping him calm or upsetting us all by seeing him through a window."
Yeah.
So clearly a number of people impacted in different ways.
Yeah.
5 years on, do you think it had to be either no visitors or allowing visitors? Did it have to be either or?
Well, that is a very, very good question. I'm glad you brought that example up because the care home question often ends up considering older age care homes more because actually for those of working age or people like the example that you've raised, the impact of visiting would be lower because the impact of the virus would be lower, and so that sort of consideration should be taken into account. We got to a position over time that was more nuanced. For instance, when vaccinations were rolled out, having a difference between those who'd been vaccinated and those who hadn't. When PPE was more widely available, allowing visiting with PPE. For instance, with hindsight, we know that COVID-19 spreads much less outdoors. Yeah. So visiting outdoors and at a distance would be safer than visiting indoors. So the more nuance and consideration you can bring into this, the better. So it isn't just a binary of no. Visiting or not visiting. It's how to do the least risky visiting. Like visiting and seeing people through a window, is very low risk, for instance. But obviously, as this example shows, doesn't work in all cases.
No. Do I take it that had there been enough PPE, that might have enabled some visiting to take place sooner than it did?
Well, it took some time to know how the disease spread.
Yes.
So, as visiting restrictions were lifted, then at that point, PPE was more widely available. And as you saw in the discussion that we had when we required face masks in hospital settings, one suggestion from one of my advisors, it was to have the PPE available when visiting restrictions were eased. So this is, in fact, an area of work, again, a bit like so many others, that consideration and thought should be put into it now so that more nuanced versions of policy can be put in place rather than having to invent it on the fly.
Yeah. And do I take it that if there'd been enough testing, that might have enabled at least some visiting?
Yes, and in fact, I think once testing was available to the general public, that was used as a, if you have a negative test, then visiting is more highly recommended. Again, you've got to have policy, and then sometimes policy isn't rolled out on the ground exactly as intended, not least because of the issues of accountability and authority that we talked about just before the break. So all of these things should be considered, yes.
All right. Can I just would like to ask you about one document that impinges on visiting restrictions, and indeed the lifting of them. Can I ask to have up on screen, please, 327939_1. This is a submission that went to both you and the Minister in July of 2020. There was a proposal to publish updated guidance on visiting policy, and clearly it says there in the timing it was urgent. Visits remain a source of concern for many families and friends of care home residents, and they were keen to publish the guidance as soon as possible. And can I just look at the rationale for change with you, please, Mr. Hancock? Clearly, as we all acknowledge, there was making changes involves an increased risk of transmission. It must be balanced against the significant impact on the care home residents from being isolated. ONS data, as at the 3rd of July, shows that between March the 2nd and June the 12th of 2020, only 29% of deaths in care home residents were COVID-related. The deterioration of the physical and mental health of vulnerable people is likely to have been impacted by loneliness. One only needs to look at the final line, reference there to carers, representatives and residents who are, to quote, fading away. Over the page, you received, or annexed to it, I should say, was some sage advice that highlighted, as at July, there was medium evidence to suggest that visits of short duration, where appropriate social distancing and infection control measures are adhered to, are likely to pose a lower risk to residents than the risk of infection by care home staff. And then there was good evidence about the benefits of the residents seeing their visitors and their loved ones, and the detrimental impact on them of not having visitors for an extended period. And in due course, you were content for the guidance to be published in July. When we move forward to the winter of 2020 into 2021 and rising transmission rates again, you say in your statement that you took a hard line on loosening visiting restrictions. Can you just explain to everyone, please, why it was you considered in the winter of 2020 into 21 that hard line was required?
Because transmission rates were high and even higher than they had been in the first wave. Certainly measured rates were higher than in the first wave. And if you look at the analysis of who had COVID, it's highly likely that the real world rates of COVID were higher in the second wave, and therefore visiting was a significant risk again in a way that it hadn't been by July. In the middle of July 2020, the number of infections measured was only in the hundreds, as opposed to the tens of thousands by December 2020. So that's the reason. I'd just say that on the previous piece of advice that you've showed, that shows the degree of thought and consideration that went into this question.
I don't think anyone's suggesting that there wasn't a degree, and there's no easy answer here.
Exactly, yeah.
But what I did want to come to ultimately, though, was your reflections on what we should do in the event of a future pandemic vis-à-vis visiting restrictions, when perhaps there isn't testing and there isn't a mass of PPE available. Would you still propose and advocate for an outright ban at the outset?
Well, I'd propose having a testing system that could be expanded quickly and having stockpiles of PPE that could be picked. So let's try to avoid being in that position in the first place next time round, please. But taking the question at face value, visiting restrictions are a reasonable measure. The more that you can introduce nuance into them, the better, taking into account the infection risk and the impact of not having visiting, exactly as this piece of advice did. Technology is probably now more ubiquitous than it was, and people, especially older people, might be more used to using it. And that helps relieve some of the lack of connection and the loneliness. But of course, it's not the same as face-to-face, and face-to-face isn't the same as physical touch. We all know that. I think it would be a very useful piece of work to think through in advance what is the best way to have the least worse outcome in this space.
You mentioned there testing. There's just one aspect of testing I'd like to ask you about, please, and it's testing for domiciliary care workers. Obviously, there was some access in April 2020 for symptomatic testing of domiciliary care workers, but in fact, asymptomatic testing for domiciliary care workers was not introduced until November 2020, and in fact may have been not rolled out until January 2021. Can you help with why asymptomatic testing of domiciliary care workers was not rolled out until November 2020?
Well, this was about the access to tests, so it's not quite right exactly the way you put it, because of course asymptomatic testing was available to the general public by then, and so domiciliary care workers would have had access to tests just because they're members of the general public should they have wanted to. And therefore, I don't think the problem is quite as acute as set out. I can't remember the exact timescales around then of when the huge quantities of lateral flow tests became available, but that was essentially the breaking open of testing from a controlled to a widely dispersed issue, if you like, and that was in the autumn of 2020, wasn't it, when we got the first mass hundreds of millions of lateral flows through, and made the whole issue easier.
New topic, please. And I'd like to ask you about changes to the regulatory inspection regime.
Right.
Did you agree with the decision to suspend routine regulatory inspections?
Yes.
How were you assured of the safety and quality of care homes in the absence of those inspections?
I thought two things on that. The first is that whistleblowing was still possible in the worst extremes, and the second is that it was a necessary short-term measure given everything else that was going on and the risk of bringing COVID into care homes through inspections, but also that many inspectors are themselves medically trained and were needed on the front line.
In your statement, you said, I supported the CQC's decision to suspend because I wanted hospital and healthcare workers' primary focus to be treating patients rather than complying with inspection requirements, and to free up inspectors' work to work directly on the front line.
Yeah.
The reference there to rather than complying with inspection requirements may to some sound dismissive of the importance of inspections. Why did you phrase it in that way, Mr. Hancock?
So I'm a supporter of inspections, but the reason I phrased it in that way is that these were extraordinary times. Care settings and hospitals were doing unusual and extraordinary things, and sometimes one of the reasonable criticisms of most inspection regimes, including the CQC's, is that they can get box ticky, and what the last thing you want is somebody making a decision based on a worry about a future imminent CQC box ticking exercise when there is life-saving work to be done. It comes back to my overall, the way that I led the health system was to presume that everybody would be doing their level best to do the right thing. And part of my job was to give them the tools to do that, but then get out of the way of their ability to do that. And that was the overall approach that I took within the health system. And this is just one example of that. You know, there are times for CQC inspections. The middle of a pandemic is not one of them.
Right. Can I ask you about reference to box ticking? Because can we have up on screen, please, a text message or WhatsApp exchange you had with Peter Wyman, the chair of the CQC, at INQ 419147_002. And thank you. I was wondering if we can expand it. It's from the 16th of March, Mr. Hancock, which is the day that the announcement of the regulations, the routine inspections being stopped.
Yeah.
And you say, in return, I need CQC to pull back more than they are currently planning on inspections and data collection. We are likely going to have people in hotels, and it's important. Should that be hospitals?
I don't think so. What date is this?
16th of March.
Yeah, so this is...
Who was going into hotels? Who was going into hotels?
People who couldn't fit in the NHS.
Right.
This is before the Nightingales have been built.
Yeah.
You can see that I'm worried about... This is before we have got the legal lockdown in place.
Yeah.
It's when rates are still climbing very quickly. So I think that we are going to have people end up with people in hotels.
Right.
Remember,
Understood.
the Italian experience a few weeks earlier had been that people were their health system was completely.
So you're
overwhelmed.
worried that that's a position we're going to end up in, and people are going to have to be going into hotels. It's important people do their best without worrying about box ticking.
Yes.
And that may to some sound like that you think inspections are just honoured more in the form rather than in the substance.
No, it's that inspections do have an element of box ticking. And box ticking is a pejorative term. But what I mean by that, and there's a reason that there is some of this, is that in order to make inspections consistent between different inspections, there are structures and frameworks which naturally have to get written down, which can then become box ticking exercises. It's the nature of the system that you end up with box ticking. I don't like it, but it's true. Anybody who's had a child go through GCSEs knows that to get the points, you have to do a load of exam technique, which is essentially box ticking. That's because they have to be able to compare exams from one person to another. I use that analogy because it can also apply in hospital inspections, and I wanted the CQC to basically completely pull back from this sort of activity, except where they thought there was serious harm going on.
A safeguarding concern or neglect or abuse.
Exactly. And Peter Wyman, who is a very great public servant, understood that. He naturally would have been concerned to ensure that the CQC did its job. So I was pretty firm in my request to him. Remember, CQC is independent, rightly so. So I couldn't direct him, but I was asking him, and he is coming back saying, we've pulled back on inspections only where we think there's abuse or serious harm, and that's fair enough.
All right. So given that you were supportive of the decision to suspend routine inspections, did you ask for any information or assurances from the CQC as to how residents would be protected and the quality of care maintained?
I considered that a matter for the CQC, and I'm sure I would have discussed it with them, but I also wouldn't have worried about my need to insist on that to them, because that is their natural purpose.
Right. So were you aware of what was planned to replace the routine inspections once they were suspended, or did you leave that to the CQC?
Absolutely matter for the CQC.
Right.
It wouldn't have been appropriate for me to have done that. I was basically giving a directional steer, which is, you've got my cover if you can go as far as you can and feel you are able to in this direction.
Given that at this time there is now inspectors not going in routinely to care homes, there aren't visitors now going in routinely to care homes, there is an increased use of remote consultation by GPs and the like. Do you consider that perhaps there was now a lack of the checks and balances that would normally be in place in the care sector?
Absolutely, there was a lack of the checks and balances that are normally in place, but I don't think that was a mistake.
Right.
but it was, of course, a downside consequence.
In your statement at paragraph 260, you state, at the weekly ASC Adult Social Care meeting on the 17th of April, so about a month after the inspections have stopped, you specifically asked for an update on whether care homes could easily flag quickly to the CQC if they were facing serious issues.
Right.
What prompted you to ask for that update, Mr. Hancock?
No idea.
Right.
So it seems like a reasonable question to ask.
Right. Do you remember now what response you got to? No.
No.
Concerns, however, were raised with you about the lack of inspections. I'd like to show you just one example of a letter that you were copied into. Could we have on screen, please, INQ 231915? Thank you very much. Although it's to the then Chief Executive Ian Trenholm, at the bottom of it you're copied in. I just want to look at some of the concerns that are being raised about the lack of inspections. We can see there in the second paragraph that the Relatives and Residents Association say it was clear from the outset that care services would be in peril. We looked at that Public Health England February 2020 guidance earlier. The CQC failed to speak out immediately to refute that. The CQC announced that routine inspections of care homes would be suspended. With family visits banned in most care homes, many residents felt totally abandoned. Then they go on to talk about the CQC producing an emergency framework, which doesn't include detailed policy or practice guidance, and concern there about the lack of oversight and scrutiny that has been compounded by easements and various other measures that were put in place. Do you remember, perhaps not this particular letter, but having those concerns raised with you by family members of people who are resident in care homes?
I remember considering this as a balance, and that's the challenge. You see, often in policy, especially in these terrible times, we were taking actions in order to preserve life. Those actions had some negative consequences. We all know that. And a letter like this is an entirely reasonable expression of one side of the argument. And of course, you see letters like this. I don't know whether I saw this one or not. You have considerations like this brought to you. You have considerations brought on the other side, and you have to make a judgment. That is that's the nature of governing. So, you could read out any number of totally reasonable reports of people who found it deeply upsetting not to visit, not to be visited, and not to have a CQC inspection. The challenge is that on the other side, there were, in my view, greater risks of having taken the other decision. So it's just a question of balance.
Were you concerned at all about the lack of oversight?
I was concerned about it, but I just think in this one, in the scales of this decision, the balance was so far down on the vital importance of protecting people in care homes and of getting everybody who could to work on the front line in a national catastrophe that, in my view, this was not a balanced decision. It was a very clear decision.
Okay. You go on in your statement to say that you met with the CQC on the 1st of July, and in fact Helen Whately was also meeting with the CQC on the same day. And I'd just like to look at some documents in relation to the 1st of July. Can we start with, please, INQ 609960? This is a summary of the meeting that Helen Whately was having on that day. She met with the CQC, and towards the bottom of page 2, if I may. There we are. Can we see the bottom 2 notes there? The Minister asked KT, who's a member of the CQC, whether KT was confident that right and timely steps were taken to ensure people weren't neglected. And KT noted cautiously that whilst the right measures were taken, given the example of a care home, that was closed due to lacking of basic safety for residents. It's likely we will see an increase in the number of services that haven't been able to cope during the pandemic, and therefore a spike of these cases being unveiled in the next few weeks. KT stood by their decision to stop routine inspections. The Minister agreed, but still unlikely to uncover bad cases in the next few weeks. And the Minister asked if we could get more insight into the CQC's findings in terms of latest and live intelligence, especially where there were known alarming cases.
Yeah.
Now, were you made aware there was a potential concern that there was going to be inspections that did start to uncover bad cases of care in care homes?
I can't specifically remember that. I may have been. It might have been brought to my attention, but it's also obvious. If you stop infections, you'll find more things out later that have gone wrong in a system in which hundreds of thousands of people reside. There are always problems. Again, I come back. You've got to remember that the flip side of this is a very high amount of death that was happening in care homes. So that's the balance that we had to strike.
Can I go to page 1 of that email chain, please? And you're not in it, but the Minister, Helen Whately, says, thanks, Ros, for the email. Sorry, it's being relayed to the Minister. I flagged with the Minister, but on the call, Kate, who is the lady from the CQC, suggested a level of detail the Minister does not recognise. Given us the Minister's real concerns by Kate's admission that we should expect cases to emerge in the coming weeks of potential neglect, abuse, poor standards of care, she's asked, is there a way we can get them to expedite inspections? Can we get more formal information? Do we have internally a sense of what the scale of the issue is that may be about to erupt? She's clear that while she agreed with the CQC decision to stop routine inspections, she did not agree that this was done at the risk of neglect, abuse to residents. And Kate, the lady from the CQC's comments today, did not assure her on this point. So clearly the Minister's got real concerns about what's going on. Does that help you remember whether this was brought to your attention?
No, I'm afraid it doesn't. This level of detail is exactly what I would expect the Minister to do. She's doing her job exactly as she should. The key to me reading this, obviously it's the first time I've seen this and I wasn't involved, but this first sentence, on the call, Kate suggested a level of detail that the Minister does not recognise. You'll have to ask Helen about it, but my interpretation of that is that she's been given reassurance that everything's fine, and she's challenging and finding out that the level of detail behind the reassurance is not adequate. That's my reading of it, but obviously I wasn't. I wasn't involved. This is one level of detail, more detailed than I would have got into.
Right. You said
because the key point is here. She was clear that while she agreed with the CQC decision to stop routine inspections, right? So that's where I would have got involved. This is essentially about, okay, where's the boundary of routine inspections? Where do you need to go in? What's the limitation of and implementation of that policy? If there'd been a recommendation from Helen in response to this to say we must go back to having routine inspections, that's when it would have been brought to me.
Right. Would you not expect, though, concerns that they are going to find potential cases of neglect, abuse, poor standards of care to come to you as Secretary of State?
No, I wouldn't been. I'm not sure whether we did see that eventuality occur. You can't bring everything to the Secretary of State. I think we would have anticipated that there'd be problems from not having inspections. That's why you have inspections. But again, I come to the balance, which is you can look at all of these different things that we had to do to save lives, and many of them had downsides. I'm acutely aware of that. They needed to be managed, and what this is doing is managing that decision to suspend routine inspections, but with a consensus on the core policy because the alternative is more people dying. And I know I return to that over and over, but it was our lodestar. It was the thing we were concerned about more than anything. We didn't care about the personal brickbats, the comms, except in as much as it affected people's behaviour. We cared about reducing the number of people who were dying in their thousands, and we took decisions accordingly.
Can I just ask you a bit more about this, please? Because at the deep dive that we looked at earlier, and if we can have back up on screen, please, INQ 40900302_007. Sorry, not the deep dive, the COVID-0 operations meeting on the 23rd of October. There is reference during the course of the discussion to there being 696 breaches. We can see it there at point I hope, Mr. Hancock, you can see it. 696 breaches of regulations identified since the start of the pandemic. The most common of the breaches were in relation to Regulation 12, which was the regulation around the provision of safe care and preventing avoidable harm or risk of harm. I know you've said to us that it was really a matter for the CQC as to how they assured themselves that residents would be protected, but you've had letters of concern. Helen Waitley is receiving alarming messages from the CQC about what might be uncovered. By October now, there's nearly 700 breaches of regulations. Do you think, in fact, you should have asked more questions for assurances about how people were going to be cared for and protected?
I did ask for those assurances, and you saw right at the start my text exchange included considerations around this, even in the initial response from the chair of the CQC. So this was clearly at front of mind from the very start of this policy. 696 breaches of regulations in a sector that cares for hundreds of thousands of people over what by now was a 6-month period needs to be put in that context, and in the context of thousands of people in care homes who died. So I think it's I think it's entirely an entirely reasonable set of decisions.
Right. There is a contrary view, I suppose, from some that given the level of transmission, the outbreaks, the death data that we've looked at, and the vulnerability of the people in the workforce, and the fact that perhaps training and use of IPC, and in particular PPE, was not as good as it was. In fact, there was all the more reason to have inspections. What do you say to that counter-argument?
I don't think it's correct. I think it is a, there's many cases when people put policy ideas or suggestions of different ways of doing things that didn't take into account the fact that if you drive up contact between people, then you drive up the infection rate. And it sometimes isn't a popular view, but actually the life-saving thing to do sometimes is to be firm on these things. Add to that, in this case, the fact that CQC inspectors were also incredibly important on the front line, and that's the balance that you've got to put to reach an objective decision, given those considerations. To me, the question that's really important in this discussion is, were these things considered when a balanced decision was taken, and they very evidently were, and a decision then taken in the round.
Two final topics, please, before perhaps some overarching observations from you. You have previously given evidence to Her Ladyship on a number of occasions about the case for vaccinations as a condition of deployment.
Yes.
And clearly it was applicable to the consultation, indeed in due course the rollout in the social care sector of that policy.
Yeah.
Do I take it that you stand by the observations you've previously made about the case for why you consider vaccination was necessary as a condition of deployment?
Yes, I absolutely do. And I think that we should have vaccination against flu and COVID as a condition of deployment in social care and in the NHS at all times, because I think that given that these diseases can pass on without the person who has it knowing, it is a dereliction of duty to fail to take up the most straightforward and proven of scientific defences. And in fact, I again, it's something that people can make unpleasant personal criticisms of me for taking such a strong view of backing the science in this space. When we did bring in the vaccination condition of deployment, again, lots of people said that there'd be thousands of people leave social care and there'd be a huge gap in the workforce, and there just wasn't. And just before one of the breaks, you read out a bit of vitriol against me. I've been and looked into it. It turns out it's somebody who is arguing against vaccination as a condition of deployment. I mean, vaccination does, for some reason, cause people to feel very strongly against it for some reasons, and we can see in America that can have very negative consequences, and measles rates are going up as a result. It's a real social problem in our modern society post the pandemic. But none of that means that I change my view that we have this amazing scientific device called a vaccination. We have an incredibly well thought through logical processes to know when it is safe and effective. And since it is safe and effective and cost effective to vaccinate against flu and COVID, I can't for the life of me see why, if you're a care worker and therefore care about people, you should allow yourself, or if you're an employer in that space, allow the people who work for you to take this totally unnecessary risk. So in short, yes, I agree with the view that I expressed earlier.
Thank you. Different topic, please. You set out in your statement that at a Downing Street press briefing on the 15th of April, so the same day as the action plan was announced, you made this statement: and we're making crystal clear that it is unacceptable for advanced care plans, including do not attempt resuscitate orders, to be applied in a blanket fashion to any group of people. This must always be a personalised process, as it has always been.
Yes.
And we know in due course that there was the CQC report, both interim and indeed final report. But can I just ask you, when you stand back and look at the pandemic and how it developed, do you have any observations or insight as to why it might have been that people felt necessary either to apply a blanket policy or an inappropriate policy of DNA CPRs?
I only saw this happen once, and we jumped on it, and I talked about it in public at the time. It is totally unacceptable to have blanket DNRs. There is a concern amongst a small number of people who focus heavily on this, that this was more widespread. If it was, it didn't come to my attention, and if it did happen, it's totally unacceptable. My own reading of it is that this is one of a number of narrow conspiracy theories that have grown up in this space. But if I'm wrong, then it absolutely must be addressed, and the inquiry should uncover that. So you're quite right to ask the question. I suppose the reason that it comes up as a question is similar to those people who demanded that we at a ministerial level, or Chris Whitty at a senior clinical level, should make policy according to who gets care and ration care. I disagreed with that as well. And but it's in the same category. I think the concept is abhorrent and is rightly denigrated. And if it does happen, it should be stopped. In fact, I think it's illegal, and if it isn't, it ought to be.
Final few questions from me, please. At the very beginning of questioning this morning, I asked you about the inadequacies of some of the local authority pre-pandemic plans.
Yeah.
And we touched on that. But looking forward, who do you think should have oversight of whether those plans are in fact adequate? It's no good us just saying they were inadequate. Who should try and ensure that they're not?
That's a great question. I haven't thought about that. My instinct is UXA maybe the best place to make a judgment on it. Again, it comes back to this problem of accountability in the care sector, because whoever makes that judgment needs to then have the teeth. So it may well be that the CQC may be the best place to actually make the decision, because then it would have teeth amongst the sector, because there's no point in some body with no teeth making a view clear on this. That was part of the problem before. So it may be best the CQC, but if I could, I may come back to you if I come up with a better answer.
Please do. Finally, then, we've looked at a number of different aspects of the response to the pandemic as far as it impinges on the social care sector. You've obviously made a number of observations about limiting staff movement. We've looked at the hospital discharge policy. We've looked at visiting restrictions. Is there any other area or recommendation that you would like to bring to Her Ladyship's attention?
Well, the only other area I think is in terms of a register of care workers. Now, to bring in vaccination as a condition of deployment, we had to have a register. Ensuring that register is has been brought in effectively and continues is, I think, important. Of course, that won't include unpaid carers.
No. Can I just pause you there? Can you summarise in a nutshell what value do you think the register would have had in the pandemic? If you'd have sat there on the 13th of March 2020 and there'd been a register, what practical difference would it have made to you and the things that you could do on behalf of the department?
Well, it would have meant that it would have been easier to bring in mandatory ban on staff movement, because you have to have some way of enforcing that and therefore of knowing who is working in the sector. We had to find a way to define working in care sector for vaccine prioritisation, because of course care workers were in the first group of people able to get the vaccine. It would have allowed us to distribute PPE, especially in domiciliary care, more effectively. And all these questions around sick pay would have been easier to address in practice. But I think that's important. And then maybe the final point comes back to this governance issue. Understanding. I hope I've been able to explain it. I haven't explained it as well as you did, Milady. Understanding why it is hard to drive policy in this area is vital, and it is a real practical problem. You expressed surprise when I said that as Secretary of State I couldn't do something. That was in relation to PHE. Secretaries of State are very powerful, but there are limits to that power, and rightly limits to unilateral action, because we're a plural democratic system. Ensuring that the accountability aligns with the levers of exercise of that power is the basis of good governance, and that is a core problem in this space.
You spoke there of a number of the benefits from your perspective had there been such a register. Who do you consider should be responsible for compiling such a register?
Probably the CQC, I would have thought.
Mr. Hancock, they're all the questions that I ask. Thank you very much.
Thank you. Mr. Weatherby.
Mr. Hancock, I asked questions on behalf of the COVID bereaved Families for Justice UK group, which is a group of 7,000 family members who lost loved ones across all four corners of the UK. I'm going to start with PHE and data, if I may. You've discussed already with Ms. Carey the position of PHE generally and its ultimate closing down. and you discussed data, including with reliance on their reports regarding transmission into care homes. Earlier this week, I referred to a WhatsApp exchange between you and Helen Waitley on the 13th of July. I just want to go through that with you now. So could we have it up on screen, please? It's 274068 and it's page 19. Have you got that? So it's the entry 13th of July, 1820. Helen Waitley, we've received a PHE update on the new care home outbreaks. Some were not reported before. Some are from blanket testing and some are suspected but not confirmed. I find their report frustratingly vague and dismissive about new outbreaks. I've asked for a proper breakdown of how many fit into each of the categories above, going down to named individual care homes, and want to avoid a zero tolerance approach. I want to adopt a zero tolerance approach to COVID in care homes. Every single outbreak should be treated as a problem requiring immediate action and investigation.
Yeah.
And you replied, totally agree, we should have zero tolerance for both COVID and crap data.
Yeah.
Remember, PHE described Leicester to me as progressing positively 4 days before lockdown. It was only because I blew up that imprecision.
I blew up at that imprecision, yeah.
Yeah, that they acted. So, can you help us? You've been Secretary of State since July 2018. Had you had concerns about PHE and the data they produced prior to the pandemic?
Well, prior to the pandemic, the PHE's focus was almost entirely on non-communicable diseases, and that is part of the reason that they needed to be abolished, to replace them with an agency that concentrates only on infectious communicable diseases. Of course, I'd seen some data, but we discussed earlier, the data from the care sector was terrible before the pandemic.
I'm going to come on to that, but had you, just very short order, had you had concerns before the pandemic about PHE data?
Not specifically about PHE data, no, before the pandemic, but I did very early in the pandemic.
So very early in the pandemic, you start to realise that the data that PHE are producing is poor. You get...
Well, not all of it. I mean, PHE's early scientific work was excellent on the tests, for instance.
Right.
And you've got to remember that the lack of data here, it's not fair. I've been quite critical of PHE. It's not fair to criticise them for the fact that many of the facts that we didn't know early in the crisis because it was a novel disease, and so getting the data sorted was really important.
Well, okay, that's really the question I'm coming to. First of all, when did you realise it was a problem, and what did you do about it?
Right, so we knew that there was a huge problem of lack of data on the spread of the disease very early. The chair's point earlier today on the difference between measured tests and actual numbers of cases is a vital question that we asked ourselves very early. For instance, we didn't know how many people had contact with COVID and therefore had got antibodies until we got the ONS survey going. So this was a major issue at the start of the crisis.
Yeah, so what did you do about it?
We improved the amount of data radically over the period of the pandemic. And what you can see here is that by July, I have a zero tolerance approach to crap data. And by then, we were getting better and better data in certain spaces, but clearly not good enough in this space.
So by July, what you're expressing is not only concern about this data that's being discussed, but also the general quality of PHE data.
Well, by July, a lot of the data had got better. It still wasn't as good as it was in the autumn. You know, I come from a tech background. I understand data. I found it deeply frustrating, for instance, that early on, when we needed to know how many people have been infected by PHE, infected by the virus, the first attempt to get that survey, PHE had gone to blood donors to get the blood to do the test. But of course, to be a blood donor, you have to declare that you haven't been ill for the last 2 weeks.
Yes.
So it was
Okay.
effectively useless. So we got the ONS in to do that survey instead, and they came out with the answer.
I don't
So
want
that's
to cut across you, but we've got to crack on time-wise. But do you think more should have been done by you in terms of sorting data out earlier on and recognising the shortcomings that PHE and others had in their ability to gather the data in quick time at that point?
We did absolutely everything we could, and coming from a technical background in this space, it was an area that I leaned into incredibly strongly.
Should this have been something that had been fully considered in preparedness for a pandemic?
Well, it absolutely needs to be sorted for next time, yes. And I think it will. The quality of the data now available is significantly better, and there are programmes across the NHS and UXA to improve on this.
On the 3rd of April 2020, you received a briefing ahead of a healthcare ministerial implementation group from the Healthcare Secretariat, signed off by Simon Ridley. And it included this: we have not focused on social care to date, given immediate priorities for the NHS. However, we recommend turning to this, given the large-scale discharge from NHS that has been required, the risks in this sector, and the need for a strategy to manage COVID in care homes. This will assess the overall social care strategy, including discharging, capacity and functioning, workforce and resilience, and guidance to care homes. In Module 2...
Could you just tell me what date that was that you've read out?
that was the 3rd of April.
Okay.
In Module 2, Ben Warner, a special advisor to Number 10, told the inquiry, from the start of COVID, it was obvious that care homes were hugely vulnerable, and I was constantly worried that there was not sufficient attention being paid to them. And Professor John Edmonds told the inquiry from SAGE that hospitals and care homes were potential high-risk environments was not a surprise. It's clear that not enough was done in February, March 2020 to reduce this risk. So question to you, taking those three passages into account, do you accept that not enough was done in February and March 2020 to reduce the known risk to this highly vulnerable population in care?
Absolutely not in the areas I was responsible for. So if we go through those three in turn, the first is from Simon Ridley in the Cabinet Office. It's important to mention that when you read out his statement. Simon Ridley is a fine official, but his statement there is that by the 3rd of April, the Cabinet Office had not considered care homes enough. It doesn't mean that we hadn't in the department. We've been working on it since January. Ben Warner is an exceptionally intelligent and capable individual, and he is saying at that point that Number 10 had not engaged enough on care homes. We know from Module 2 that Cabinet Office and Number 10 were making all sorts of complaints. We were getting on with trying to fix the problem. So we were engaged in trying to solve this as well as possible from January 2020, as you can see in all of the paperwork.
Yeah, well, I mean, the person putting those three pieces to you is it is from the Cabinet Office, from Number 10, and from SAGE. So it's three different sources. Another way of looking
But they're not. But hold on, that's not right, because the Cabinet Office statement is that they have not turned their attention to care homes. It isn't that the department hasn't. So it's the fact that you read it out without mentioning that it was from the Cabinet Office kind of demonstrates that the point that we were working to solve this problem. We had, it was in some areas, the Cabinet Office had been blocking the work that was needed. In other areas, they were, Number 10 were going slow, for instance, on some of the publications that I wanted to make. But we, in the department, were working as hard as we possibly could.
Okay, well, I'm certainly not trying to hide that it was from the Cabinet Office in the way that I read it out.
Right.
One way of looking at those three pieces of information or evidence that I've read out to you is that the we refers to whole government. This was a briefing sent to you about a ministerial group meeting, and the professor is talking about not enough generally being done across government, isn't he?
I'm so sorry. The Cabinet Office saying that that they have not considered this yet, as in the healthcare interministerial group, is not in any sense saying that there hasn't been attention paid to this. It is saying that the healthcare ministerial group from the Cabinet Office, of which I was chair, had not itself considered it. That's a piece of bureaucracy which, in fact, came and went because it wasn't seen to be effective.
I'm not going to fence with you. The inquiry has the material. The inquiry can make its own.
Yeah, but
the question.
I'm merely responding to the fact that you are misinterpreting a piece of information, and in your opening statement didn't even say who said it. So. And then you're putting a quite serious accusation that's wholly false based on a misreading. So that's
which I think you've answered.
Yes, thank you.
Put it again just for clarity. Do you accept that not enough was done in February and March 2020 to reduce the known risk to a highly vulnerable population in care homes?
No, I do not.
Here's your answer is no, you don't.
No.
In a readout of a social care COVID meeting from your private secretary, it records that Ros Roughton asserts that domiciliary care is in effect an emergency service. Do you agree with that statement, that domiciliary care is in effect an emergency service?
That isn't how I'd put it. It is a vital service to those who need it, but an emergency service implies both that it might be short-lived and it might be needed in an unexpected way. Both of those may be true occasionally, but generally not. Generally, it is planned rather than emergency, and generally it is long-term rather than short-term.
Let me move on to leavers, and you've given a bit of evidence about this already, so I'll be quick about this. You've repeatedly referred back to the fact that as Secretary of State, you didn't have the levers to act when it came to adult social care, and that you led on policy and guidance only for the sector. Is it right that that was something that you knew before the pandemic?
Yes.
And certainly early on in the pandemic?
Yes, I knew, as I said earlier, I knew that before I became Secretary of State, yes.
So why did you not do something about that to increase the levers that you had, certainly to be available in an emergency?
Because that would have required a change to the 1948 settlement that set up the NHS, and I wouldn't have been able to get cross-government agreement for such a radical change.
Right.
Effectively, that is the only way to solve that is to bring in what would effectively be a national care service, which was not something that the government was considering.
Right, but is that something that should be done now, that levers should be available for the Secretary of State for Health and Social Care?
Well, my recommendation is that there do need to be levers available. We invented them, in fact, in the early part of the pandemic, as we've discussed, with the linking of emergency payments to action. And so I've made some recommendations in that space, yes.
So would it be right to say then that your view is that it would have been preferable had those levers been available prior to the pandemic, so you could have used them straight away?
Yes.
Given that they weren't, why did you not put levers into the Coronavirus Act or some other convenient legislation in the early part of the pandemic, if it was such a problem?
Yes, so it's a good question. We did bring some measures with respect to adult social care in the Coronavirus Act, and selected the measures that were available in the preparation. So in the legislation that had been prepared in response to Operation Cygnus. So that had been part of the preparation. To a degree it was used, but I think that there's more to do. Right.
So the fact that you refer back to the absence of levers to act, is that then an excuse for things when they went wrong, they weren't your fault? Because if you were putting these levers into place with the Coronavirus Act or other convenient legislation, then you could use them.
That is a very easy thing to say with hindsight. The reality of the situation is that I had to act with the tools that I had. And that's what I did, and drove the life-saving effort to make sure things weren't even worse than they were.
But you brought levers in quite early on with the Coronavirus Act, and that gave you the ability.
Well, in this space, the most effective things that we brought in were the requirements in return for the emergency funding. That's what really brought the meant that we could bring to bear policy that we had not foreseen the need for before the pandemic.
Yes. Okay. Let me move quickly on. I want to ask you some questions about Operation Nimbus. And I think we're going to need the document for this. So it's INQ 195891. So Nimbus, you chaired it, and it was a tabletop exercise conducted on the 12th of February.
Yeah.
And therefore, very much with the pandemic in mind, even though it was an exercise of itself. No doubt you've had a chance to review the notes of Nimbus. Can you help us? Because from the notes, it appears that there wasn't any discussion about how the government was going to ensure that people discharged from hospitals could be discharged safely and the right time, given the known problems with the adult social care sector.
I've discussed the problems of exercise Nimbus before. So these exercises are are developed by the Cabinet Office and put to ministers, and they are best done exercise as if real. And the main thing that came out of exercise Nimbus was the fundamental problem of the wrong doctrine that underpinned it. And the problem with Nimbus, it was much, much worse than what you imply in your question. The problem with exercise Nimbus is that we spent, however long we spent, an hour and a half, I think, talking about body bags, dealing with how we solve the problems that are a consequence of an unmitigated pandemic, where we don't take action to save lives. And I came out of Nimbus, and this was the real penny drop moment when I realised that the doctrine that had underpinned the pandemic planning, both in the care sector but also across the board, was fundamentally flawed. And this is well expressed in Module 1, the Module 1 interim report of the inquiry.
Yes.
Hold on, let me just explain this point, because it's critical to answering your question. From the 12th of February, when I walked out of this meeting and thought, I am not going to preside over this pandemic just ripping through the population, I had to change not just the policy, but the underlying attitude across the board in a whole series of areas. And it took me the work of the next few weeks to do it. The concept of lockdown was not considered in Nimbus, and we had to get that going, and the publication on the 1st of March was vital to it. The testing was stopped because that was part of the underlying wrong doctrine from PHE, as was contact tracing, and I had to get testing going again and rebuild contact tracing. No, I'm going to answer your question.
Mr. Hancock, the trouble is that Mr. Weatherby has an allotted time, and to be fair to his lay clients, which he's trying to do, they have a number of issues they want put to you, and he has permission to ask. So if you could just listen to the question, please, to be fair to the people, the bereaved, that Mr. Weatherby represents.
Thank you very much. So I'm not asking about the underlying doctrine. If you look at paragraph 17, you yourself as chair ask for an update on adult social care and the problems are set out there. So not only have you got the pandemic well over the horizon coming towards us, so well in mind, but you also got in mind the adult social care's sector's inability to cope. So my question was, why wasn't there any discussion of how the government was going to ensure that people discharged from hospitals would be discharged safely and at the right time, given those known and acknowledged problems?
There was endless discussion of that. There was endless discussion, and we've been through some of it this morning.
Okay.
The point in Nimbus itself is that the whole exercise was based on the wrong doctrine with respect to your question very specifically, and the point I was rather at length explaining is that was true right across the board, and changing the attitude in PHE and amongst the assumptions underpinning the response in social care and in this module and on your question was just one part of having to change that attitude right across the board.
I've been through the note. If I missed it, someone will point it out.
No, it's not in the note here. It's in the notes of what we were actually doing in response to the actual pandemic that was coming.
So there's been a discussion, has there, about discharging patients safely to residential homes?
There were endless discussions about it around this time. Yes.
It's just not recorded.
No, it's in loads of the notes about real world discussions we were having about the real pandemic.
Can you help us as to why no one was apparently invited to Nimbus on behalf of the social care sector?
I was invited to Nimbus on behalf of the social care sector.
Well, you're the minister.
Yes, that's right.
But looking at the participants in Nimbus further up, there's nobody there, as far as I can see, from the social care sector. So why is that?
Well, because this was a ministerial meeting, so I was there as the Secretary of State for Health and Social Care. That's the technical answer. But there is a wider point that you make that's important, which is that whereas the NHS has a chief executive who can represent them, there is no such figure. The closest we got was David Pearson, who did a fantastic job. But he did that job. It's not the same as having executive authority over a whole sector. It comes back to the accountability point we were making right at the start.
Well, you say it's a ministerial meeting, but you've got people from the NHS there.
Exactly.
But you've got nobody from adult social care. I fully understand what you're saying. You've got a chief executive for NHS, but you're not looking for people to express responsibility in an operation, are you? You're looking for people who can put impact into how those sectors or those organisations would react given what's going on in the exercise. That's what you really want in an exercise, isn't it?
No, this is not a stakeholder exercise. This is a ministerial exercise for decision making. So you need the people with decision making authority, and there isn't anybody beneath ministerial level with that sort of decision making authority in social care. It's one of the problems that we talked about earlier. If you could possibly go on to page 2, you see Helen Whately is there.
Minister.
The minister, yes, but ministers have responsibility for this in social care. That's right.
Before I move on, would it have been improved as an exercise had there been somebody from the adult social care sector involved in it?
That's the problem. Who? There isn't a chief executive. There isn't a Simon Stevens or Keith Willett counterparty. That's one of the problems.
Staying with Nimbus, but moving to a different topic, older people. So the minutes record that you, paragraph 8 of the minutes, asked what were the key decisions to make, and NHS England clarified that the committee needed to decide whether to expand the intensive care capacity as a consequence of stopping treatment to others, and following that decision that doctors' regulations are updated to reflect treating by likelihood of survival by years of life left. Now, am I right that that means that older people were less likely to be prioritised for treatment?
This was a recommendation by Simon Stevens that I rejected. I rejected it here in the exercise, and then I rejected it when the BMA later made it on behalf of their doctors' union later in real life. Right.
So the answer to my question is that, yes, this does reflect a view of prioritising less likelihood that treatment would be prioritised for older people.
It reflects that proposal that was put forward and rejected.
Yes, I see. And again, in those minutes, can you help us with what alternatives were actually put forward by you or by anybody else and minuted?
Alternatives to what?
Well, this proposal is put forward. You say you rejected it.
Yes.
But what is the rejection that's recorded in those minutes? What is it that the alternative that you say, no, I'm not having that?
No.
So
that's right.
the way we'll prioritise treatment or the way we'll do it differently is this. Where's that?
A rejection of a change to this approach left us with exactly the same and normal approach, which is that the doctor on the ground makes a decision as to the appropriate.
Yeah.
Let me finish my answer because it's quite important. It's that the doctor on the ground should make that decision. That was my view, strongly supported by Chris Whitty as CMO. But it was exactly this sort of discussion that made me determined to ensure that we would stop the pandemic rather than just let it wash through, and that made me realise that the doctrine that had been underpinning the planning was wrong. And it is a deep irony that it was the Department for Health team who spotted that,
yes,
with me at the helm, and went on to solve all of these problems as much as we possibly could in the circumstances.
Right.
That is what I did. And representing some of the bereaved families as you do, that is the work that we had to do from this point onwards.
Okay, so this is what's thrown up in the exercise. You realise here that what's being said to you is that we need to prioritise in a way that just basically discriminates against older people, and you reject that.
Correct.
So where is it in the minutes about what you're going to do in the alternative?
Well, the alternative was, what this led to, ultimately, was the policy of lockdown.
Yeah.
Because lockdown wasn't discussed in these minutes either, because it wasn't proposed as part of the plan.
So there's nothing in this minute of Operation Nimbus which says Secretary of State's rejected this view that was put forward, horrified at the idea of discrimination.
Can you go on to the conclusions? Because the chair asked what key decisions to make.
Yes.
I have a feel. I have a. If you go up a page, back a page. I'll have to read it because there is
I don't want to.
there's two. I suppose there's 2 points. The first is I rejected it, and it's there in the minutes somewhere. But the second point is that this is the exercise. In real life, the BMA brought this proposal to me, and I rejected it in the pandemic itself. So
that's not my point, Mr. Hancock.
Okay.
The point is where is your alternative here? You've got the exercise, you've got the proposal. You say you rejected.
Yes.
But where's the alternative?
The alternative is the status quo, which is that doctors make decisions on the ground.
At 12th of February, we need to realise that in order to avoid this discriminatory proposal, we need to do X, Y, and Z. And it's not there, is it?
No, because it's the status quo that I was supporting, and therefore I didn't need to set it out. It was that we're not going to make such a change.
Finally,
the NHS was recommending a change to me. I rejected the change. I didn't need an alternative. I needed people to do their job, which is what doctors went on to do, which was to treat everyone. And my job was also to try to stop getting into a position where you even have to choose.
Yeah.
I did not want the rationing of care, and that's what we achieved.
Well, you did need an alternative. You needed isolation and testing and PPE.
Yes, and I went on to build all those things. Exactly, yeah.
Finally, on Nimbus, there appears to have been discussion about staff absence in the healthcare sector with respect to communication about it, but no discussion about staff absences in the adult social care sector. Why was that?
I don't know whether that's the case. As I say, it was a Cabinet Office prepared paper. So ultimately, Exercise Nimbus was in my view, the end point of the approach of embodied in the 2011 strategy. If you remember, a few weeks before this, I'd been calling for cobras, trying to get action, been blocked by the Cabinet Secretary. They'd been quite rude about me, and they continue to be rude about me.
Let's not worry about that.
No, it's important, because what I'm trying to get you to understand is that exercise Nimbus was based on the wrong doctrine. It was the moment for me that I thought, we cannot let this happen. And then there was a whole load of action that went from it. So that's my explanation of why certain things aren't in there that really, in a future exercise, absolutely should be.
Okay, I'm not going to take Nimbus any further with you. The point I put to you is that the problem about the proposal that's being put to you, you're chairing it.
Yes.
These are the minutes. They're not the Cabinet Office briefing document. These are the minutes of it.
Yes.
There's nothing in there about all the measures that you say you agree should have been taken thereafter, and this is 12th of February.
Yes, and my response to that is that all you're doing is reinforcing the point that I would make in response to Nimbus, which is the exercise highlighted the wholly inadequate attitude that was being taken by the Cabinet Office to how to respond to a pandemic.
Mr. Weatherby, it's not your fault. You are over your last time, but we're going to take a break now. And don't worry, if you could try and work out during the break what you can do if I allow you another 10 minutes.
That's very kind. Thank you.
I shall return at 10:02.
All right.
Mr. Hancock, before we start again, I appreciate how difficult it is for you and how you wish to make sure that any criticisms that aren't fair aren't made. But there's limited time left. The stenographer's had an extraordinarily long day, and we still have a number of questions from other core participants. So please, if you could focus on the questions and just answer the questions, I'll be really grateful.
Absolutely. Could I just very quickly put on the record a little addition to the previous answer, though, to exactly this point, because I was asked about this point about who took decisions over prioritisation of care, and we could have shortcutted that whole section, because in paragraph 35 of the same paper, it says, the Chair stated that clinicians, as part of NEPP, which is the National Emergency Planning Procedure, should be empowered to make decisions. So it's stated there in the minutes. Thank you.
Yes, well, thank you for that clarification. That wasn't my point. My point was about the other issues that should have come as a result of you rejecting the proposal that was put. Two topics to finish my questions, and I'll deal with them as briefly as I can. Asymptomatic transmission. On the 14th of March of 2020, your department and the Office of the Chief Medical Officer received data on the Diamond Princess cruise ship, confirming that 696 people on board the Diamond Princess had tested positive, 328 of which were asymptomatic, and some of the cases appeared to be super spreaders. Just for the record, the reference is 48086. Can you help us that those who had been repatriated from cruise ships were required to self-isolate for 14 days and tested within 24 hours of arrival. And that had happened on the 10th of March, return of passengers on the Grand Princess cruise ship. Why were care home residents discharged from hospital at around this time not treated similarly?
The problem here was that the PHE clinical advice said that asymptomatic testing was not appropriate, and of course there weren't enough tests. I had stated in January that policy should proceed on a reasonable worst-based scenario, noting that there was evidence even then of asymptomatic transmission. You'll have to ask PHE why it didn't update its advice until April.
Right. In terms of the self-isolation point, though, the requirement for returning cruise ship passengers for self-isolation for 14 days, why wasn't that something that could be done with the discharges from care homes? For example, by things that you've already discussed about holding accommodation or hotels,
Yes.
where care homes didn't have the availability to do it themselves.
Yes.
Why was that not done?
You'll know from the discussions that we've had that that is something that ministers were pushing for But we weren't able to put that in place until the middle of April. In fact, because of my concerns about asymptomatic spread, I'd insisted that people coming back from Wuhan were isolated in February, as early as that. So this was something that the clinical advice was clear from PHE. Sharon Peacock led, I think, on that advice. Okay. It's something you'll have to ask PHE.
I'll come on to that in 1 second. Just on this point of the apparently different treatment of returning cruise passengers and discharged patients, and this position of discharges in the middle of March, and then more testing becoming available with the action plan on the 15th of April. Why did you not stop elective treatments, elective surgery, for example, at the same time or before the discharges from hospital to care homes?
The NHS were working on their policy of elective discharge, pausing electives at that point. That was a decision for Simon Stevens, so you'll have to ask him about that.
That would have meant that the discharges could have been delayed until you had proper testing, more data.
Well, not necessarily, because it depended on the spread of the virus and how many people ended up in hospital. But I mean, I essentially agree with the thrust of your point. People coming home from cruises, of course, could self-isolate at home. For somebody in a care home, their home is the care home. So it is more difficult because there isn't a place automatically to go.
That's why I put the point about the holding centres. Right. Finally, onto asymptomatic transmission more generally. You've said today and in your statement that the initial consensus that the virus could transmit asymptomatically underpinned many decisions, including, for example, the department's initial advice on the management of the virus in care homes. And to be fair to you, in your statement, you set out your reservations about that.
Yeah.
But does it follow that if you had worked on the precautionary assumption that the virus could transmit asymptomatically, you would not have supported the decision to discharge patients untested in March 2020?
Oh, not necessarily. I think if there had been concrete evidence and clinical advice of asymptomatic transmission, that would not necessarily have changed that policy, because, for instance, then we would have known that asymptomatic transfer in hospitals would have been more prevalent, and therefore hospitals would have thought to have been even more dangerous settings than they were thought to be at the time. So I don't think it follows that a policy assumption of asymptomatic transmission at that stage would have changed that policy. It's a difficult counterfactual question, but there is a case that, in fact, it would have made the policy as enacted.
I follow that. Your case is that there weren't enough tests available, hospitals are dangerous places. But the question is that you would have stuck to the same policy decision.
As I said, it's a difficult counterfactual question, but there is an argument that, in fact, knowing about asymptomatic testing categorically at that point might have made the policy choice that was made more rather than less strong.
Yeah. Now, you say that, finally, you say that you'd received advice from PHE that tests didn't work reliably on asymptomatic individuals.
Yeah.
Were you made aware of any evidence that was based on?
Oh, I was advised this repeatedly by my clinical advisors from early on. There was then a disagreement that we went through in a previous module between Chris Whitty and Patrick Vallance on this point. I asked for advice from the two of them, and a month later, Patrick Vallance finally came up with that advice. So we went through this in the previous module.
And did you suggest or consider ordering, as Secretary of State, a trial of whole care home testing, for example, in one of the locations with an outbreak to test?
We did that when enough tests were available, when we'd expanded the testing capacity. But as you know from another module, that took longer than it should have done, and I had to take personal responsibility for making that happen.
Bearing in mind the answers you've given, even if it was necessary to go ahead with the discharges without testing being available, was it something that you considered to only require care homes to accept patients if they had facilities to isolate them? Is that something you...
Yes, so we did consider that at the time, and the problem was what you do with people who don't have that available, and the point about the danger of hospitals remains the same. So,
okay, but you would have had a position where maybe half of the care homes or three-quarters of the care homes in a particular area had isolation facilities, so you would have had that capacity, and then you've been able to consider what to do with the others.
Yes, but all of that presumes that people are safer in hospital than in a care home, and I don't think that was true at the time.
Nothing further, thank you.
Thank you very much, Mr. Weatherby. Next, I think it is Miss Beattie. Over that way, Mr. Hancock.
Thank you.
Mr. Hancock, I ask questions on behalf of disabled people's organisations. You gave evidence this morning that it was when you saw the two local authority plans that you realised that local plans were as good as useless, I think you said.
Yeah.
Now, in June 2018, which is just before you were appointed Secretary of State for Health and Social Care, a department briefing paper on pandemic influenza in adult social care and community health care had highlighted that exercise Cygnus in 2016 identified, quote, a knowledge gap in community services preparedness.
Right. I don't think I knew that.
Including for adult social care. So do you agree that the adult social care sector's lack of preparedness for a pandemic was well known prior to COVID-19, including to your department?
I can't testify that because I haven't seen the evidence that you refer to. If that's what it says, I didn't know that until you just said it.
And so you didn't have to see those two local authority plans to know about the knowledge gap in community services preparedness, is that right?
I can only testify what happened to me and what I did, and it was when I saw those plans that I first realised that that was a major problem.
Had you made any investigations between becoming Health Secretary and the outset of the pandemic into that level of preparedness?
Yes. I was briefed when I became Health Secretary on our pandemic preparedness plans, and I went back in some detail with Clara Swinson, who was the lead official, on this question.
But you weren't told what was in that June 2018 paper?
No, not that I can remember.
Now, at the beginning of March 2020, Counsel to the Inquiry took you to the coronavirus and social care meeting of the 6th of March this morning. Do you remember that?
I do. I remember it very clearly.
And at that meeting, you said the impact of COVID posed a complicated set of problems for the social care sector, which needed to be gripped as soon as possible. You recall that?
Yes, that's right.
And I think at the same meeting, the Minister for Care, Helen Whately, said we need to ramp up preparedness around social care. Is that right?
Yes. The essence of this meeting was when the department decided, and it was my decision ultimately, but it was a strong consensus in the department that we needed to take responsibility for what was going on in care homes, irrespective of the fact that some of the policy levers were not our formal responsibility. We just decided that nobody else was doing it, so we had better had.
And you say care homes, I assume you mean social care generally.
I do mean social care. Thank you for picking me up on that. You're quite right.
So having decided that at the beginning of March 2020, why did it take until mid-June 2020, almost 3.5 months after you thought that, there was a complicated set of problems which needed to be gripped as soon as possible, and what you've just told us, to set up the Social Care Sector Support Task Force?
That's a misrepresentation of what happened. What happened after the 6th of March meeting was immediate action on a whole series of fronts. We saw earlier the minutes from that meeting saying that I'd set out 10 different areas in which we needed to take immediate action, and a huge amount happened from that moment onwards. the social care task force was a way of bringing together a disparate sector in a way to have a formalised engagement with the sector that on recollection, was led by the minister rather than by me, largely. But that was it comes back to the problem that we were discussing with the bereaved families group, that there is no single leader of social care. At that, I've looked at the minutes at the exercise that we just talked about. Clara Swinson was there as a departmental official leading on social care and was part of the discussion. So she was doing that job, so it was done. But there wasn't a sector-wide formal grouping in that sense, and so I understand that's my recollection of why the task force was set up. It absolutely does not imply a lack of action.
Right, but are you telling us that it wasn't until mid-June 2020 that it occurred to anyone that formalised engagement structure needed to be put in place?
No, I'm not saying that. There was a huge amount of engagement, largely led by Helen Waitley and the civil service team, Ros and the rest of the team. It was put into a task force form. It's a reasonable thing to do.
One of the things that task force was set up to do was to oversee the social care action plan. Is that right?
I don't recall.
Right, I think that's stated in the letter that you sent to David Pearson on the 17th of June,
right.
Setting up the task force.
Okay.
And that social care action plan had been published in mid-April 2020. Is that correct? Sorry, you understand the action plan was published in mid-April?
If that's what you're telling me, you mean the 15th of April document?
Yes.
Yeah.
And would you agree that it's not very useful to set up a task force to oversee delivery of an action plan that had been published 2 months earlier?
Nope, I don't think that's true at all. I think we published the plan and we got on with delivering the plan. The plan itself changed the advice in a way that reflected the now agreed clinical recommendation of assuming asymptomatic transmission, for instance, and many, many other things. A huge amount of further work was done, including the changes announced and the extra money announced, for instance, on the 15th of May and many other times. Formalising that after this period of intense activity into a group that could take it forward, led by somebody who from the sector, and David Pearson, was a good next step. It was entirely reasonable to do it in that time frame.
And you've given evidence already that it was your department was overstretched and had no levers. So was it an overstretched department with no levers who had been overseeing that action plan?
Of course, we were all unbelievably busy responding to the greatest civil emergency in 100 years. So yes, we were busy, yes.
The next March meeting, which Council for the Inquiry took you to, was the 11th of March. Do you remember that? It's the social care coronavirus meeting.
I don't remember that specifically. It wasn't as momentous as the previous one.
Right. Well, I'll ask the questions and you can tell me if I need to bring up the note of the meeting. But it is a social care coronavirus meeting of the 11th of March, at which there was discussion of speeding up hospital discharge.
Right.
Do you accept that?
I don't know. It was 5 and a bit years ago. So
right. Well, if it assists the witness, it is INQ 000328131.
Could you get an on ask the question while it comes up, Ms. Peters? Sorry, short of time.
At the meeting, there was discussion of whether everything was being done to speed up hospital discharge. A discharge to assess option was proposed, which you agreed with.
Right.
And just to put that in context, is it right that discharge to assess essentially aims to discharge patients from hospital sort of as soon as possible, as soon as they no longer need acute care, but they might still need care services and that would be assessed once they're out of hospital? Is that right?
That's the definition of it, more or less, yes.
And you were at that time trying to free up tens of thousands of beds, and so discharge to assess was accelerated. Is that right?
Yes, and that's entirely reasonable if you don't clinically need to be in hospital but do need continued help, making sure that the assessment of what continued help is needed is done after discharge is an entirely reasonable way of going about things.
So what safeguards did you understand existed then to ensure that patients who were discharged to be assessed did in fact receive full assessment of their support needs once they were out of hospital?
Yes, it's incredibly important that they do. For instance, we were putting in place at the same time the financial arrangements to make sure that the initial period of care was paid for in all instances, rather than having to be assessed for payment. So removing the financial barrier to getting that care was one of the steps that we took. Because what you wouldn't want to do is to undertake a discharge to assess without a care package in place. And normally the care package is agreed in negotiation, and it's based on the assessed care needs, but instead we simply put the care packages in place.
Now, you're aware, I presume, of Healthwatch England survey material, which showed that, in fact, in the first 6 months of the pandemic, 82% of respondents did not have their recovery and longer-term support needs assessed. Nearly 1 in 5 of these reported having unmet needs. 45% of people with a disability and 20% of people with a long-term condition said they had support needs that were not being met following their discharge.
Yes, well, you need to consider that evidence alongside what is the normal reported level of unmet need in that group, because some of those needs will be significant in normal times as well, because we're generally talking about non-COVID needs of those who are in hospital for non-COVID reasons. The one possible explanation for why the proportion of those who didn't have assessments is so high is because we were paying for the care irrespective of a needs assessment, whereas normally the payment only comes following a needs assessment, and therefore the needs assessment is critical to unlock the payment. So ironically, the generosity of the support for the care sector and the £5.1 billion that I outlined may have led to fewer assessments being done, along with the fact that this was in the middle of a pandemic, so people would have had other priorities as well.
Right, so that's the formal aspect of, you're talking about the procedural aspect of the assessment, but are you aware of any auditing of discharge to assess cases to ensure that patients have not remained post-discharge in unsuitable placements and without adequate support and needs being met?
I'm not aware of whether there was or there wasn't. It's a level of detail that you'll have to ask Helen Waitley, or maybe one of the officials. It wouldn't have come to my desk.
I'm afraid you're going to have to wrap it up. Thank you, Ms Beattie. I'm sorry that we're in such a rush this afternoon. Thank you, Ms Weston.
Good afternoon, Mr Hancock. I'm asking questions on behalf of the Frontline Migrant Healthcare Workers Group. We represent care workers who were at the sharp edge of the pandemic.
Yeah.
Our questions concern how the employment conditions of workers in the adult care sector impacted on the spread of the virus.
Yes.
Could I ask that we turn up INQ 88388, which is the early draft of the Adult Social Care Strategy document. If I can ask you to look at 0020, which is paragraph 2.27. So in that paragraph, we can see that the proposal was for paying workers their full wages for up to so many weeks of sickness or isolation during the pandemic.
Yeah.
And that where local authorities faced particularly disproportionate costs, government to meet the costs, brackets policy not agreed with ministers.
Yeah.
And then if it wasn't happening, you'd want to know, and you would work with those representing care workers to ensure there's a way that staff can flag if they're not getting that support through.
Yeah.
And then if we cross-reference that with INQ 88629, which is the minutes of the COVID-0 meeting at which that draft strategy was discussed.
All right. Yeah.
Page 4. It explains the reasoning for rejecting that statutory sick pay proposal as follows. The commitment in paragraph 2.27, which is one I've just taken you to, might cause difficulty for the government as it would be the first time the government acknowledged that statutory sick pay was not appropriate.
Yeah.
And clarification would be needed
Yeah.
about why the policy wouldn't apply to all key workers who've been declared as essential.
Absolutely.
So my question is this: do you accept that it was well understood at an early stage that an increase in statutory sick pay was needed to protect care workers and service users alike, but that it wasn't immediately adopted or ring-fenced?
Yes, it's safe to say I campaigned in favour of that. I was strongly in favour of the language that you highlighted in yellow, 2.27 in the previous document, and I would have made the case for that in this meeting, but clearly didn't get my way.
Well, wasn't the reason to save the government the embarrassment of admitting that statutory sick pay was inadequate across the board?
No, I thought that statutory sick pay was inadequate, and I still think it's inadequate, and I made that case firmly. So
how would you describe then, could you explain what was the nature of the difficulty that such a policy would present for the government that's referred to?
This question wasn't suggesting that was your issue.
No, I know, but all I can do is tell you what I think. I think statutory sick pay should be higher. I don't think there's a difficulty. That point would have been made by somebody else. I lost the argument.
But presumably you were at meetings where that was discussed.
Yes.
What the objections were discussed. Can you help us with that?
No, because I don't recognise them. I don't think there are any.
So you didn't hear anybody talk about any objections?
Well, I can't remember, but lots of people make rubbish points that you forget, don't they? I mean, the implication of the question is that there should be better statutory sick pay. I strongly agree. I can't think of reasons not to, other than the direct cost of it. The direct cost, in my mind, is massively outweighed in normal times, let alone in a pandemic, by the benefits of such a policy. I apologise that I can't remember what the people who unfortunately won the argument at that time said in doing so. I regret that they won the argument, and I think that the government should sort out statutory sick pay now, and I would recommend that to the inquiry.
Just moving on.
Yeah, sorry.
Dame Jenny Harries has noted in her witness statement for My Lady's Notice, paragraph 913, the financial position of the carer also served to encourage them to return prematurely to work when staff in other sectors would have isolated, supported by adequate sick pay.
Yes.
And that's because of the nature of the peripatetic workforce.
Yeah.
So given that subsequent scientific evidence, I'm thinking particularly of the Vivaldi study, did confirm the link between inadequate sick pay and the spread of the virus.
Yes.
Firstly,
yes.
Understanding that it wasn't your decision to take, but do you regret the decision?
Of course, I disagreed with it at the time. I'm sorry I can't be more used to you other than to say that you're completely right.
Mr. Hancock, I'm going to move on to the position of domiciliary care workers.
Yeah.
So you accept, I think, and you've already recognised today, that workers in domiciliary care are frequently on 0 hours contracts working multiple jobs.
Yes.
Do you accept that they're also frequently migrant workers on tied visas?
Yes, frequently and disproportionately, yes.
And that and they are also undocumented workers who have come to the UK legally but whose visas have expired?
I haven't seen evidence of that myself.
These were important aspects of the sector, the significance of which I suggest was overlooked by government when looking at the impact of working conditions on the spread of the virus. Do you agree?
I agree that the decision by the government that I had argued against, by its nature, therefore, didn't take into account this important factor.
For example, whistleblowing for a care worker in such a precarious position would be impossible, even in, to use your language of a short while ago, the worst extremes, wouldn't it?
Yes, it would. Well, it depends on the exact circumstances of the worker. I strongly support those who are in the sector, and I absolutely recognise, and we all should, the huge contribution of migrant workers in this sector. I do not endorse the continued employment beyond the period of their visa of workers in that situation. And I think that the policy that I proposed, some of which became policy, some of which didn't, reflects that balance. I think it's a reasonable position to take.
Mr. Hancock, do you accept that the government's pandemic strategy suffered from a lack of understanding of the realities for this cohort of workers who were already at the bottom of the hierarchy?
No, I don't think that we in the department failed to understand the situation. I think the situation was exceptionally difficult because of the nature of the virus. The question is a very reasonable one. You're saying, was there a lack of understanding? There wasn't a lack of understanding. It was just really hard.
Thank you, Ms Weston.
Those are my questions for you.
Mr Straw. Mr Straw's over there.
Thank you. Mr Hancock, I represent John's campaign, the Patients Association and Care Rights UK. In January 2021, Helen Whately pushed to have visitor restrictions relaxed.
Yes.
You refused, and you said that this was because we needed to save lives.
Yes.
Could I have on screen, please, a document INQ 000 492 343? Thank you. And you can see this is a letter here from, we can see from the bottom of the page, John's campaign, Dementia UK and others.
Yes.
Addressed to you, dated 2nd of July 2020.
Right.
I'm just going to refer to a couple of aspects of it, and then I'll ask you the question, please. So it refers there to the hidden catastrophe taking place in care homes. A little further down, much suffering and a deterioration in mental and physical health among many of the residents because of the ban on all visitors. This enforced separation has had particularly damaging consequences for those living with dementia, who make up over 70% of the population of care homes. And then a couple of paragraphs down, what's more, without these essential family carers, the cognitive ability of a person with dementia can deteriorate rapidly. This enforced isolation from family and friends can be fatal. There's been a significant rise, 52%, in non-coronavirus-related deaths for people with dementia. At that time, were you aware of this type of evidence, that restrictions on visits themselves cause many deaths as well as other widespread harm?
I was aware of the difficulties caused by the restriction on visits, yes.
Was this an area of data lack, where you didn't have enough information as to the seriousness of the harms, including deaths and other illnesses caused by visitor restrictions?
It's true that the data on this improved over time and was weak at first. It is something that we considered in making the difficult, balanced decision about visiting.
In terms of recommendations for a future pandemic, in order to ensure that the data on this very important area is better, can you recommend any changes? For example, the better involvement of stakeholders representing those with lived experience in information coming to government? Well,
I largely left it to, delegated to Helen Whately, the discussions with stakeholders in this space. As you've seen from the earlier discussions, I essentially took her advice in this at this time. I understood these considerations. I also had a duty to ensure that as few people died as possible overall, and this was, as I said, a difficult balance to strike. I'm sure that the policy over time can be improved by consideration now about how you can have better options, essentially, but ultimately, visitors were one source of bringing the disease into care homes, which we had to take seriously.
Well, looking at that side of the picture, were you aware of evidence that permitting visitors by an essential care supporter with appropriate safeguards, and so, for example, a negative test, PPE, limited contact with others, didn't greatly raise the risk of harm from COVID? And to give you one example of that evidence, the Department of Health and Social Care's paper on the winter plan, dated 15th September 2020, said there's currently little evidence that visits are a source of outbreaks.
Yeah, so firstly, I was absolutely aware of that sort of evidence, and it was duly considered, as your question implies. Second thing is that the case rate in September 2020, whilst rising, was still relatively low, so that might explain that statement. Whereas by January, the case rate was absolutely off the charts and extremely high. So the level of background prevalence of the disease is a very important consideration, which is why the rules around visiting changed over time.
But even in January 2021, in terms of an essential care supporter, would you accept that the balance of harms, so the harms that would be caused by refusing access to essential care supporter, clearly outweighed the risks of harms through COVID of allowing them in?
No, that wasn't my judgment. On the contrary, in January 2020, the disease. January 2021, the prevalence of the disease was at the highest point that it had been throughout the entirety of the pandemic, higher than in the first wave, and it was when the vaccine program was only just getting going. If you recall, the rate shot up over that Christmas period, and it was it was extremely serious. And so my guiding principle then, as throughout, was to save lives, and that's why I took the decision that I did. I think the balance actually was pretty clear.
Would you accept that in decisions like this, the harms due to COVID were prioritised over the harms from other causes?
No, that isn't how we operated. Right from early on, Chris Whitty set out the direct COVID harms, the indirect harms due to COVID, the non-COVID harms, and we took all of these into account. That was a really important principle of how we did things.
A linked but slightly different question. So going back to CQC suspending its routine inspection,
yeah,
and a question linked to that, do you accept that the vacuum of oversight that was caused by that could and should have been mitigated by giving a right to visits from an essential care supporter to each person who's living in a care home?
I think that is, when prevalence of the disease was low, that would be a reasonable option to consider. But I think the challenge with all of these policy proposals is you have to set them against the cost of increasing the likelihood of people dying, and that's what we did.
A different issue now about PPE. You covered this earlier, but there's a slightly different question you haven't been asked. So guidance dated the 16th of March 2020 advised that the provision of care within the home should continue as normal essential care. However, you didn't decide to provide free PPE for extra resident unpaid carers nationally until 20th of January 2021.
Yeah.
Would you accept that the needs of unpaid carers for PPE should have been met well before this, particularly when their essential role in the home was noted as early as March 2020?
Well, that is a very, very good question. There were a number of challenges there. The first is that we didn't have enough PPE, and you'll know from the whole PPE module the extraordinary lengths that we went to buy more PPE, and the challenges that in turn threw up. So that's the first thing to say. The second thing is, as per the previous discussion, defining who is an unpaid carer is hard. I think this is an area where we could seek recommendations from the inquiry for the future, because there should be more PPE more widely available in a future pandemic, and the concept of a definition of an unpaid carer is improved. There's been a lot of work done on that, including during the pandemic. So I think I think it was a reasonable judgment at the time, but it is an area where we should be better prepared in future.
And so, may I do one final question, my lady? Is that my time?
I think you've had your time. I'm sorry, Mr.
No problem at all.
I'm
Thank you
really
very much.
sorry. Thank you. Right, Mr. Pater.
Hancock, I represent the National Association of Care and Support Workers, and the topic for you is the vaccination as a condition of deployment.
Yes.
CQC registered care homes. And at paragraph 247 of your Module 6 witness statement, you said that the concerns about the mandatory vaccination policy raised during the consultation period, quote, especially about staff leaving these caring professions, did not materialise.
Yes.
And indeed, you repeated that evidence in response to a question from Ms. Carey this afternoon.
Yep.
Item 56 on your evidence proposal is a record of a meeting of the COVID-19 Operations Committee on the 31st of January 2022. Could we have INQ *0091577, page 6 on the screen, please? And just while that's being brought up, Mr. Hancock, at that time, the government was considering revoking the policy and associated legislation, which had been in effect for about 2.5 months. And as we'll see on page 6, your successor as Secretary of State, the Right Honourable Sajid Javid, was recorded as having said that there was a, quote, estimated 19,000 people who had lost their jobs as a result of the policy. And you will know from your own time as Secretary of State that 19,000 job losses were well within the predicted estimated range as set out in the legislative impact assessment. So, Mr. Hancock, in view of all of that, do you accept that the concern about the reduction in workforce capacity as a result of the policy did in fact materialise as predicted?
No. This was at the lower end of estimates. And you've got to put this in the context of around 2.5 million people who work in the sector. The turnover in the sector is significantly higher than 19,000. It didn't have a material impact, no.
Well, Mr. Hancock, the 19,300 figure was the net reduction in the size of the workforce in the relevant period and takes into account both normal turnover and new staff joining and staff leaving. And in December 21, a survey undertaken by your former department of workers gave the second most likely reason to leave as the policy. So again, in view of that evidence, do you accept that it did in fact lead to a reduction in workforce capacity?
No. The number isn't material in the context of the normal turnover of a workforce of 2.5 million people, and you're modelling up gross and net numbers to say that people left because they chose not to be protected against harming people in their care. They will have been hiring to replace them. So no, it didn't reduce capacity, and the actual number of people who chose to go down that route was lower than the central estimate in the impact assessment. So I absolutely stand by the position. And in fact, the lesson from this is that vaccination of a condition of deployment has a lower impact than we had feared before bringing it in, and therefore the balancing item, the only argument you can make against it, the only moral argument in my view, is weaker than we thought at the time. The logical case in favour of vaccination of a condition of deployment for people in caring professions is absolutely categorical, stronger than when I brought that policy in, and is a deeply ethical and moral policy.
Thank you, Mr. Pater. Mr. Burton. Mr. Burton's over there.
Thank you, my lady. Good afternoon, Mr. Hancock. I ask questions on behalf of the TUC.
Yes.
The first topic I want to ask you about is financial support for people working in the care sector, and in particular the Adult Social Care Infection Support Fund.
Yes.
Now, I'm going to refer to that as the fund, if you don't mind.
Okay.
It's true, isn't it, that as a consequence of the paucity of statutory sick pay, and the general insecurity and low wages in the sector, that a particular problem was that employees in the care sector stood to lose out very significantly if they were required to self-isolate.
Yes.
And as a consequence, that posed a risk for care workers properly being tested because of fear they would have to self-isolate.
A risk, that's a reasonable way of putting it, yes.
And that was one of the reasons the fund was set up, wasn't it, to address that risk?
Yes.
And the way the fund worked is that 75% of the grant that would go to care providers had to be allocated to specific measures, including paying staff full wages if they were off work because of self-isolation,
Yes.
but also to ensure that they could employ more staff if necessary, and indeed limit the use of public transport by staff, and indeed, if necessary, provide them with accommodation. That's right, isn't it?
I will take as read the points of detail, but broadly, yes.
Now, those objectives were discretionary on the part of the providers, and as early as June 2020, a month after the fund was set up, Unison warned the department that they were worried that providers wouldn't actually use the fund to pay staff who were self-isolating. Were you
Yes.
aware of that warning?
Yes, I was aware of both that concern and the concern that some of the fund hadn't yet reached the providers from the councils. So the flow-through of the fund from Treasury to MHCLG to the councils, then to the providers, and then to staff had, frankly, drop-off at every point.
So there were problems with the flow, but the specific problem of reluctance on the part of care providers to use this money to pay individual care workers who couldn't work because they were self-isolating. Were you aware of that discrete problem?
Well, I didn't personally see evidence that I can recall now, but I wouldn't be surprised at all. Certainly, you know, in a sector of 2.5 million people with tens of thousands of providers, I wouldn't be surprised at all if some of that flow-through didn't happen.
Well, Mr. Hancock, the evidence is that by October, 4 months after that warning, only 25% of employers were using the money in that specific way, i.e. to compensate workers who were self-isolating. Were you aware of that problem?
I'm surprised that the figure was that low.
You're surprised it was that low?
Yes.
As in, you would have imagined a higher number of employers to have been doing what they were asked to do in accordance with the fund?
Yes. Are you saying that only 25% were doing what they were asked to do?
Yes,
in
only
accordance
1
with
in
the
4
fund?
were using the fund for that purpose.
Yeah,
Were you
not
ever
good
made
enough, is
aware
it?
of that? Were you ever made aware of that?
I may well have been, but I don't specifically recall.
Do you ever remember taking any specific steps to address that?
Well, this comes to the point of levers that we've been talking about all the time. It was not within my direct bailiwick to be able to put requirements on these funds, because that was a matter for MHCLG in agreement with Treasury. So it all comes back to this problem of governance again.
Can I just ask you one further question on that then? Did you ever invite either of those 2 other departments to stipulate that that money should only ever be made available to a care provider if they did indeed use it to mitigate infection control by ensuring they paid employees their full wages if they had to self-isolate?
I can see where you're going with this. I essentially agree with the thrust of the question. I wouldn't be surprised if I had asked for that to happen. The decision would have been outside my departmental purview. It would be a more, if we had paperwork, I'd be happy to go through it, but it was a long time ago now.
Can I just ask you one final question on a different topic then, which is just about the suspension of routine inspections by the CQC? Mm-hmm. You gave effectively, I think, 2 reasons in broad terms for your agreement that those inspections should be suspended.
Yeah.
One was that there was a risk of tick box exercises getting in the way of fighting the pandemic, if I can put it that way.
Yep.
But the second one was perhaps more important, which was that you wanted to ensure that any medically qualified inspectors were available to be redirected towards, as it were, the front line.
Yeah.
Now, if that second reason wasn't necessary, let's imagine a future pandemic where we were prepared properly. We didn't have to rely on dragging in employees from other departments or other agencies like the CQC.
Yeah.
In those circumstances, would you have taken a different view? And would you have recommended that inspections carried on?
Well, we still may have needed an adjustment to inspections because of the fact that the frontline workforce would have been doing unusual an unusual array of things. So I'm not categoric about it. But your broader point I agree with, which is that if we hadn't had a fear of the NHS being overwhelmed, then we wouldn't have had to take such drastic decisions. But that, of course, applies to a number of areas, and it comes right back to the doctrine point at the start, which I've agreed with the TUC representative on before, which is when a pandemic strikes, you don't have a choice about whether to lock down or not. You have a choice about whether to lock down at a low prevalence, where some of these negative consequences could be mitigated, or at a high prevalence when you have to act in the way that we had to in this instance. You don't have a choice of not locking down, so you should get on and lock down early. That is the single most important thing that the inquiry and the nation can learn. I fear currently the nation's learning on that is going backwards, but I'm in total agreement with you that the impact on things like CQC inspections, which overall are a good thing, would be lesser if the response was early and robust.
So in other words, the inspections could have still happened with some modifications if it wasn't necessary to redeploy the staff who will otherwise be carrying them out.
I think it's better to answer that question in the future. In the future, I would wish the action at the macro level to happen sooner, and therefore fewer mitigations like pulling staff from CQC to put them into frontline situations would be more avoidable.
Thank you, Mr. Batten.
Thank you very much.
And lastly, we have Ms Wilkinson. I appreciate there are a number of matters that the CQC wanted to correct, but don't worry, we don't have to have oral evidence. We can do that another time. So we just have the one last question. Thank you, Ms Wilkinson.
Mr Hancock, I ask questions on behalf of the Care Quality Commission, the independent regulator of health and social care in England. And I'd just like to clarify the one matter in relation to something you've said on a number of occasions. And most recently at paragraph 39 of your statement for this module, regarding the absence of a list of care home providers.
Yes.
You understand now, and understood at the time in 2020, that what underpins CQC's ability to regulate care home providers in England, or to use your phrase earlier this afternoon, what gives it its teeth, is that it is a criminal offence to provide care home services without being registered with CQC, isn't it?
I have looked into this because the CQC wrote to me, made the letter public, and said that I got this wrong. In the letter, they say that there are care settings that aren't regulated by the CQC. That proves my point. I think we're dancing on the head of a pin. There are care settings not regulated by the CQC. Our problem, which I was making clear, and I stand by, is that there was not a list of all these settings. It isn't a criticism of the CQC, but it is a matter of fact.
I'm going to be precise about the language you used, actually, Mr Hancock, because the language you used was care homes, care home providers and care homes, not care settings, not unpaid carers, not domiciliary care settings, but care homes. And you used that language a number of times, including most recently in your statement for this module. And it's in relation to care home providers that I draw your attention.
Thank you.
Because it is a criminal offence to provide care home services without being registered with CQC. That is a criminal offence contrary to Section 10 of the Health and Social Care Act. And it's in that context in which I point out to you that must obviously mean that CQC holds a complete list of all those registered to provide care home services in England.
You see, the challenge I've got is that I have sworn an oath, and I take my oath extremely seriously. And I only will say things that I believe to be true. And this has been true in all the modules.
Wilkinson's putting to you, if you just forgive me, could you just think of the question?
Yes.
Ms.
Yes,
Wilkinson,
I'm answering the question because it's
please don't interrupt me, Mr Hancock. Right. One more time, Ms Wilkinson. Please listen to the question.
Can you now acknowledge that whatever you were told by whomever in your department, and I'm referring to your paragraph 39, that it is not correct to say that nobody knew how many care homes were in operation across England, because CQC did know that. It's been publicly available on their website to download since 2012, and indeed CQC took steps to check that your department knew fully of that list as early as the 25th of March 2020. Can you now acknowledge that?
I can tell the inquiry what I was told. I put it in my statement. I stand by that is what I was told. There are other points where I've been challenged in terms of the veracity of my evidence, and I take it exceptionally seriously, and I take quite a lot of offence at being the implication that I haven't stated the facts as I was told them. And that is all I can say. And the CQC have acknowledged in their letter the complication around language, and it may be that that's what we're getting caught up on. But all I can do is faithfully and honestly tell you what I was told.
Thank you. Thank you, Ms Wilkinson. That completes the questions we have for you, Mr Hancock, except one more from me, I'm sorry. It's just going back to one of the first questions Ms Carey asked you, and it was I was thinking back to the decision to discharge patients from hospital to care homes. You mentioned that there was pressure from NHS England, I think you said, that it was a joint decision, members of cabinet, Prime Minister, everyone involved. That I totally understand. But I was looking earlier at the decision of the Divisional Court in Gardner and Harris against you and others, and that was you as Secretary of State for...
Yes, it wasn't me personally, it was my office, if you like.
Yes, but it was taken against you as to one of the decisions, which was the discharge decision. Were you involved in that litigation at all? It took place after you'd left.
So it was very frustrating because...
Just please answer the question, were you involved in it?
No.
You weren't. So you didn't provide instructions or anything?
I didn't provide instructions.
I don't want to know what they were.
No, but I wasn't given the opportunity to state what I easily could have stated, and I think would have changed the outcome of that case, which is, of course, I considered asymptomatic transmission. I was worried about it from January. And if I could have sworn an affidavit or appeared in court and said that, nobody asked me. The finding was that I didn't consider it. I couldn't believe it when the finding came out. I was like, well, hold on. I was worried about that from a long time before.
I just wanted to give you a chance to answer it, because obviously it's a decision of the High Court, and I just wanted you to say. So now at least I know.
Thank you very much for that opportunity.
Thank you very much indeed, Mr Hancock. I expect that is the last time in which we'll call you to give oral evidence. Apparently I'm not allowed to say it is the last time, but I'm pretty confident that it is. So thank you very much for your help to the inquiry. I appreciate it's been a long session today, and indeed long sessions on other occasions. So thank you. I shall now retire, and I shall be back at 10 o'clock tomorrow morning. Thank you.